Today we will talk about bone cement procedures. Bone cement procedures are used for age-related spinal fractures, meaning osteoporotic vertebral fractures where the spine can break even from minor events such as a small fall, bending, or sudden movement. They are commonly used in elderly patients with such fractures. However, I believe bone cement procedures are being excessively used, so I would like to take a closer look at their pros and cons. Bone cement is essentially powdered acrylic. When the powder and liquid are mixed, a polymerization reaction occurs, turning it into a paste. Once this paste is injected into the bone, it hardens inside the body. This is the same acrylic used for the clear dividers during COVID. A contrast agent called barium is added to make it visible on X-rays. When patients hear that we are injecting cement, they often get scared and may want to run away, but it is not construction cement. It is acrylic and safe for the human body. Orthopedic surgeons have been using bone cement for a long time. It has been used for more than 60 years in joint replacement surgeries to secure prostheses firmly to bone. It is also used in treating osteomyelitis, where antibiotics are mixed into the cement for gradual release. Bone cement can rebuild areas destroyed by cancer and reinforce weak bone during spinal fusion surgeries. It has a long history of safe use in orthopedic practice. Vertebroplasty, the injection of bone cement into osteoporotic vertebral fractures to relieve pain, started gaining popularity in the early 2000s. The effects can be dramatic, often allowing patients who were unable to sit to stand again and perform daily activities with less discomfort. At first glance, outcomes may look impressive, but there are important caveats. Complications such as cement leakage, where cement goes outside the bone, or pulmonary embolism, which is a blood clot in the lungs, can occur. Not all patients improve after the procedure, and some fractures do not respond to cement augmentation. Based on clinical experience, there are roughly 5 types of fractures that do not benefit, including very unstable fractures, severely collapsed vertebrae, fractures pressing on nerves, certain fracture patterns with high leakage risk, and fractures with kyphotic deformity, which is a forward bending of the spine. For example, if a vertebra is hollow inside, cement may leak posteriorly into the spinal canal where the nerves pass through, potentially causing neurological damage or paralysis in severe cases. In other situations, cement may not integrate fully with the bone, moving independently inside it, which results in temporary relief and returning pain. Too much cement increases leakage risk, while too little may not adequately support the bone. The amount must be carefully controlled for optimal results. Cement procedures can sometimes cause new fractures in adjacent vertebrae. One patient, a 70-year-old woman with multiple fractures, had almost every vertebra treated with cement as new fractures developed repeatedly. This illustrates the potential consequences of overusing cement without addressing underlying bone weakness. That is why, while cement procedures can be useful, they are meaningless if the underlying osteoporosis is not treated. Some might wonder if injecting cement preemptively into neighboring vertebrae could prevent future fractures. After reviewing multiple studies, the conclusion is clear. Prophylactic cement injection does not prevent new fractures. Cement procedures are often overused. While they can be very effective, careful patient selection is crucial. We must determine whether a patient is a good candidate. Cement procedures should never be overused, and their use should always be combined with proper osteoporosis management.